All right, folks. Well, welcome to the Department of Family Medicine and Community Health Forum. I'm Shelly Shaw. I'm the director of our Office of Community Health, and really pleased today to have some colleagues with us from the Wisconsin DHS Division of Public Health Office of Policy and Practice Alignment. So some folks may not know about OPA. But this office has a primary responsibility to build partnerships and to provide leadership and support through the development and recommendations of statewide policy related to the Wisconsin public health system. OPA works with partners to promote understanding of the health conditions impacting the people in Wisconsin, centering equity in public health processes and decision-making. Their major functions include capacity building across the public health system, development and implementation of practices and policies related to community health and prevention consistent with the state statute. Additional functions include overall coordination of the Preventive Health and Health Services Block Grant, evaluation of existing and proposed legislative proposals, and ensuring that quality public health programs and services are available to all people in Wisconsin. So today we have a great team representing OPA here with us today. A friend and colleague of mine, Maggie Northrup, that I was lucky enough to work with during the COVID response on the Community Resilience and Response Task Force, and two other members of the OPA team, Julia Nagy and Mackenzie Guerin. I will point out to folks that Julia is a population health fellow from the UW Population Health Institute, and I will put a link to that program in the chat. But I think it's a very important program advancing the work of public health here in Wisconsin. So I will let you all know we're going to have a few breakout sessions so folks can have some opportunity for small group discussion and have a good conversations with one another. But I'm also happy to keep an eye on the chat and elevate questions throughout the conversation as well. And just also wanting to point out, I think Vanessa put in the chat a link to the CME code. So with that, I think I will hand it over to our OPA colleagues.
Thank you so much, Shelly. And we can start with very brief introductions about who we are and what we do every day before jumping into this presentation, and just really grateful to Shelly and to all of you for having us today, and really humbled to be in your presence and excited to have this conversation. My name is Maggie Northrup, and I'm the State Health Plan Coordinator. I sit in the Office of Policy and Practice Alignment within the Division of Public Health in the Department of Health Services. It's a long description for all of us. In terms of day-to-day responsibilities and what I do, it really is, my role is very focused on coordination across the different multiple lines of effort within the umbrella of the state health plan, and facilitating the work of the team. As Shelly mentioned, we both were part of the State Emergency Operations Center efforts when the COVID-19 pandemic started as part of the Community Resilience and Response Task Force, and I continued within the COVID-19 response team until October of last year, with majority of my responsibilities being around community outreach. And community outreach and engagement and partner engagement is a lot of what I do day to day, really focusing on elevating community voices in our statewide processes and our decision making, and also much of the policy work that is happening in our policy section at the intersection of public health policy and social and economic policy. And I do bring some background from the global health work and working with immigrant and refugee populations in Wisconsin. So I'll stop here and allow the rest of our team members to step in.
I can go next. My name is Julia Nagy, and like Shelly mentioned, I am a Population Health Service Fellow through the Population Health Institute, and through that program, I am placed in two different spots within DHS. I spend probably the majority of my time, it's supposed to be 50-50, but this team really sucked me in. So I spend the majority of my time working with OPA. I'm leading the development of the State Health Improvement Plan, which is a process we're kicking off right about now that will take us through this year, and then we will have a new State Health Improvement Plan to begin implementation in 2023, and that will be a 5-year plan. And then I spend the rest of my time working in the Office of the Secretary, supporting the Governor's Health Equity Council right now and supporting the recommendations that are being developed there to improve health equity in Wisconsin. My background is a little bit of a mixed bag. I've actually worked in primary care, I've worked in health quality improvement, I've worked on evaluation, and now getting this policy perspective has been really valuable to me. I moved here for the fellowship, so I'm a recent Wisconsin arrival and just have really been impressed by everything going on here. So thank you.
Hi everyone, I'm the last member of our team. My name is Mackenzie Guerin. I am the State Health Plan Strategist. Like Julia, I spend half of my time in this role and half of my time as a policy analyst for the Childhood Lead Poisoning Prevention Program, also in the Division of Public Health. My background is in economics and sociology. I didn't plan to end up in public health, but I happened to live through the pandemic and need a job. So I found myself here and have really liked it. It's been a good fit for me. So thanks for joining us today, and we can go ahead and get started. So welcome to our presentation. Shelley, you can move to the next slide. Perfect. So for our presentation, the learning objectives today, the things we're hoping that you will all leave with is to increase your knowledge of the state health plan and its role in the Wisconsin public health system. So sort of what it is that our team does. We want to define ways for you to partner on initiatives and achieving our common goals of really improving health statewide, population health statewide. And then also describe lessons learned on the importance of engaging community voices and decision-making. This is something our team does a lot of. We think it's really important, and we also think that it's important that you do it too. Shelley, you can move to the next slide. So an overview of our presentation, so you're sort of anticipating what we're going to talk about. First, we're going to introduce our state health plan. So we'll talk about the process of developing the state health plan. We'll also talk about the outcomes of our most recent state health assessment and share with you some key takeaways. The assessment was really long, over 100 pages, and we will tell you the most important pieces so you don't have to go through that whole document, even though it's really well done. And then we'll also then move to talking about implications for practice. So implications for our public health practice, what we learned doing the state health plan, how we're pivoting and adjusting, how we think some of these implications could apply to you in your clinical practice, talking about best practices for alignment, how we can be aligned, how we can work better together, and also ways for you in your role as providers to be involved in advocating for population health and also partnering with us on our state health plan. And now I'll pass it off to Maggie.
Thank you. And we can move to the next slide if possible. Thank you so much. A quick overview of what is the state health plan. It is our public health agenda and roadmap for community health improvement on state level. And our team has very much engaged in some of the policy spaces to ensure that our agenda and roadmap is grounded in policy equity and community voices. So we're really shifting in a way the way that we're looking at the series of strategies and this roadmap for community health improvement. Within the umbrella of the state health plan, there's multiple processes, and we won't go into depth on all of them, but just wanted to mention that it includes the state health assessment as well as the state health improvement plan, two major pieces of the state health plan, which we're now doing on a 5-year cycle. And the state health plan includes kind of a planning and prioritization process, which Julia is leading currently, in which we engage with partners like yourself and communities to try and prioritize and determine focus areas for Wisconsin public health for the next 5 years. And then we move into implementation of the plan. Some of the local, federal, and healthcare system level alternatives that you may be familiar with, or you likely are familiar with, are the local community health assessments that our local health departments engage with, community health improvement plans, so CHAs and CHIPs, and the one that may be more familiar, you may be more familiar with as the community health needs assessments that healthcare systems engage with, and the kind of the federal level alternative of all of these different plans would be the Healthy People series. And I believe they started in 2000, and the CDC has recently published, well, recently, about a year ago, the Healthy People 2030. Next slide, please. So a little bit of us trying to be relatable to what you do every day. So we were trying to kind of build some parallels and in a more digestible way, introduce what we do on day to day, except that we do it slightly on a different level, on a population level. But much of the state health plan can be parallel to some of the SOAP notes that many clinicians tend to take. So we focus on qualitative data collection, quantitative, and based on all of this information, creating an assessment, and then based on using the assessment as our foundation for creating the state health improvement plan, and then moving into action and ensuring that all of these processes are iterative and engaging the communities in all of these processes, which will equate to your patients and clients that you see every day. So just a little nod here for us trying to be a little more relatable. Next slide, please. The state health assessment was a major impetus for why we're here today. We wanted to share with you a little bit about the process of the state health assessment, which is currently published, and we'll drop in the chat a link to the website. But this is our 2020 state health assessment. It was an incredibly comprehensive process in which we tried to reach to every single corner of the state, look at every single data point available to us, and try and tell a coherent story and paint a coherent story of the picture of Wisconsin's health on population level. Within this process, and I will not go into too much depth unless there's interest to hear a little bit more about the different pieces. Within this process, we looked at thousands and thousands of quantitative data points organized under 74 different indicators. So we looked at health outcomes, health behaviors, morbidity, mortality indicators. We looked at community conditions, and we tried to engage with every single piece of information, quantitative piece of information that we could find in DHS and then in secondary and primary sources. We tried to break down all of that information by every single demographic characteristic that was available to us to try and paint a more comprehensive picture and understand the existing inequities in our state. Big piece of this process was our qualitative data collection. This was an unprecedented effort that we have never engaged with before. I mean, we've had smaller qualitative data efforts, but nothing to this extent. We partnered with local health departments and their community partners in terms of elevating voices and trying to listen deeply and understand what is driving health inequities and health outcomes in Wisconsin communities. So we held 74 different listening sessions, again, that were largely facilitated by local public health and community partners. So we were just guests in those meetings. But we asked questions around what are the barriers to health in your community? What are the major conditions in your community? How can health be improved? Are there any assets that we can leverage? And what would improve quality of life and what would improve health outcomes in your communities? So those were the questions that we were really trying to capture in the conversations. And this is the information that we use to drive our storytelling and the way that we organize our quantitative data. So we can move on to the next slide. And Mackenzie can speak a little bit about some of the quantitative findings, a few examples, understanding that we have way too many to share in one presentation.
Yes. So thanks, Maggie. So we looked at many quantitative data indicators, and we decided to share this one with you. So this is what's called our death quilt. So it ranks the top 10 causes of death by age in Wisconsin statewide, I believe in 2018. So the way that you can look at this chart is that on the right-hand side, for the color that's the boldest, that shows like overall, the top cause of death was heart disease in Wisconsin. The second was cancer, then unintentional injuries. And then the other side, so the top, the more left-hand side with the muted colors, that disaggregates the cause of death by age group. So infants, people who are less than 1, the driver of death in Wisconsin was congenital malformations and then low gestation or birth weight. And what we can see from this death quilt is that the drivers of, or the causes of death across different age groups are different. And in many ways, that is really intuitive to us. These disparities that we see are life stages, and we don't expect people who are 15 to 24 to die at the same rate of things as people who are over 65. So what we can take away from this is, it's interesting. It informs how we interact with people of different age groups, how we target our interventions. It doesn't make sense to really focus, on certain conditions for different age groups. It also really foregrounds that an average can be really misleading and that disparities tell us a lot, and we should pretty much always take them into consideration. So this is our age death quilt. And Shelley, if you can move to the next slide, we also created this for people of different races and ethnicities in Wisconsin. And so what we can see here is how structural inequities lead to health disparities. So particular health outcomes that we really see stark disparities for people of different races and ethnicities in Wisconsin were diabetes. So for an average Wisconsinite, or the cause of death, it's ranked 7th for our average. But for our communities of color, so Hispanic Wisconsinites, Asian Wisconsinites, Native American or American Indian Wisconsinites, and Black or African American Wisconsinites, their diabetes is 4th or 5th. And so what we can tell is that diabetes can be managed from, sustained access to care. And it can also, for type 2 diabetes, that if people have the healthy foods that they need and they have access to exercise, it feels safe for them to be outside, that, maybe the incidence of that health outcome doesn't have to be so high. And so what we can see is how our systems and structures really do inform the kinds of things that people die from, and that's driven by policies and the environment, as opposed to just things that we expect because people are different ages. And Maggie, I can pass it back to you.
Yeah, and I just wanted to call out a couple of other ones here too, Mackenzie, I hope you don't mind. We see, along with diabetes, which is kind of stark in terms of how early it starts creeping up as a major cause of death for the different populations of color. Similarly, we see suicide and homicide starting to creep up more as more dominant and major causes of death earlier for our communities of color. And we know that in both cases, they're very largely driven by health inequities and a lot of historical policy decisions that are, and current policy decision making that is leading to those inequities. So that is an additional example of how we were analyzing the data and we were thinking about what we were seeing in the data. Next slide, please. And here's another example, recognizing that you likely cannot read this, but we'll very quickly walk you through it. Here's another example of how structural inequities are impacting outcomes. This particular data point or this particular indicator is focused on percentage of individuals who reported that they did not receive care in the prior 12 months due to cost. So what the purple lines are showing is that individuals with 4th degree education or higher reported this at much lower rate than individuals who have less than high school degrees. So here seeing a lot how educational outcomes and economics are impacting access to care. In the yellow lines there, we have the data broken down by disability status. So you can see that individuals who have an existing disability have a lot less frequently have had to delay care because of cost, and they were not able to afford care compared to individuals who do not have disabilities. We see similar outcomes in terms of race and ethnicity. We see our Hispanic peers and counterparts in Wisconsin also reporting delayed care or not having care because access to care because of cost and less access to health insurance, whereas we see whites at the bottom, or white populations and communities having much greater access. And then the age group one was particularly fascinating to me because I've not thought about it as much until I saw this particular data visualization, is that we see for individuals who have access to Medicare 65 plus, we see a lot less frequently they report delaying care or not receiving care due to cost. Whereas for other age groups, we do not see this type of, or we do see much greater disparities. I'm sorry, so all other age groups reporting much higher rates of not receiving care due to cost. Again, those were just a few examples of how we saw inequities and structural inequities everywhere we looked. And we just wanted to present to you a few examples from our quantitative data analysis. Next slide, please. And now we wanted to present to you the qualitative data themes, which were major findings from our process and may be of great interest to you. As I mentioned, this was really in the heart of everything we did in our efforts to elevate the community voices and truly try to get to what are the underlying causes of health inequities and health outcomes in our state. So the theme that dominated in terms of qualitative information by far was the need for social connectedness and belonging. Nearly every single community in Wisconsin brought up this topic, and that was an issue pre-COVID-19 pandemic. You can imagine how much worse the situation have gotten in the past couple of years. So really that need for social connectedness and belonging was truly a need that our peers in Wisconsin were telling us has major outcomes or major impact on their health outcomes. Other dominant themes that we heard in the qualitative data analysis were access to family supporting jobs and economic opportunity, access to affordable and quality housing, and access to reliable transportation, or what we often call social determinants of health. The two ones that are bolded here are two that our team thought that perhaps you'd be interested in hearing a little bit more about. The equitable access to quality and culturally relevant healthcare is probably not a surprise to anyone in the room. That came up as a pretty dominant theme in terms of importance and impact for health outcomes and health equity in the state. And then institutional bias and discriminatory practices, which had a little bit of an overlap. I was actually just looking at our analytical work prior to this presentation quickly to see what were folks sharing in the community conversations around both of these themes. So if there's interest, we can go into a little bit more depth on both of those themes. And then finally, community-based resources was called out as a really, really important condition in the community that's needed for positive health outcomes. Next slide, please.
Did you see the question in the chat?
No, I'm not great at, I'm sorry. Shelley, would you read that to me? I'm not great at navigating the platform yet.
Sure. Kathy shared with us, is it safe to say that a portion of care avoidance due to cost would be due to immigrants without papers?
I would say even for immigrants with papers, myself being one of them, access to care has also been a barrier. So we did not, in a lot of our conversations with, especially in the qualitative data, with immigrant populations, yes, undocumented was piece of it, but it was also a huge issue for our documented peers too. Sorry, and then were there other ones, Shelley, that you wanted us to address as we go
That's
along?
good.
Thank you so much. Yes, it is hard, but not the full story, recognizing that. Some of the SHA key takeaways for our team that we wanted to share with you, and we have already moved into shifting how we do the work. Based on these takeaways, we walked away understanding better how incredibly valuable qualitative data is in providing context for quantitative data. So that was also important in terms of understanding why our quantitative data results look the way that they do. So being able to ask those questions of our communities was really helpful in understanding what the quantitative data was telling us. We have been always striving to look at to move beyond averages and general population data, and we were particularly intentional with this effort, trying to break down our data as much as we could by all demographic factors available to us, and the story that emerges is drastically different than when we look at averages and general population data. Inequities were persistent and clear everywhere we looked, from health outcomes to community, social, and economic conditions, and there was very strong association and correlation potentially across community conditions and health conditions and outcomes. And the other big lesson for us from the last 2 to 3 years, including the COVID-19 pandemic too, is that it is important to address underlying factors. As much as we would very much like to target our interventions to singular disease or substance or behavior, it is also incredibly important to be able to address the underlying factors rather than the individual behavior, the substance of the day, or the pathogen of the day. Understanding that was a huge learning for us in terms of opioids. For example, our previous priority area, one of our previous priority areas was opioids, and then very quickly, within 2 years, we found out that a lot of our interventions that were very opioid specific or very focused on the substance were able to help in terms of saving lives initially, and then very quickly the substances, the chemical makeup, the substances shifted very quickly. So we had to pivot quickly, and we weren't able to pivot quickly because we were not focused on more comprehensive interventions. So really trying to move beyond a singular disease, a singular substance, or singular behavior, knowing that the substances will continue to shift, the pathogens will continue to shift, and it just feels very much like we're moving the problem around rather than resolving it. So that was a big lesson for us for the past couple of years. Next slide, please. So many of you are probably wondering, and will wonder when you see the next slide, why not COVID-19? Why isn't COVID-19 our big priority area currently? And it is, recognizing that the pandemic has shifted everything. It's changed all of our lives in so many drastic ways, but also recognizing that everything that we are going to do from now on is grounded in the work and the lessons and the learning of the COVID-19 pandemic. And the pandemic has compounded, reinforced, and deepened all of the existing inequities and deficiencies in our system. It became very clear in the last couple of years what those deficiencies in the systems were, and just how they were compounding all of the COVID-19 pandemic inequities and outcomes that we saw. We saw some communities actually faring pretty well in the pandemic compared to everyone else. We even saw silver linings and winners. In a way, we saw some communities were not impacted very much in terms of mortality and morbidity, and others really buried the brunt of this pandemic, both in terms of social and economic outcomes and in terms of health outcomes. So we were really hoping to be able to shift the way that we look at our interventions and the way that we think about what needs to happen in order not for this for the next time we have another crisis. I'm sorry, I got mixed up a little bit in my thoughts here, trying to address both why not COVID-19 and why we should focus on community and system resilience. It became very clear quickly that all of our systems were budging and collapsing under their own weight in the COVID-19 crisis, right? We saw the healthcare system really really strapped. We saw the same thing happening with our unemployment system, with our housing system, with our public health system. Our systems were really not prepared to meet the overwhelming need. And those communities who needed the support the most actually were the ones who didn't get the support. So our team is really striving to strengthen community and system resilience in order to ensure that the next time we have another crisis, all of our communities will have equitable opportunity to have the positive outcomes or the not so detrimental outcomes that we saw in other communities who had those conditions in place. So thinking about some of the reasons why people were not able to comply with public health guidance, for example. A lot of our communities, let's talk about undocumented communities just because it came up before, or other communities and workers who do not have job protections. They were not able to stay at home and isolate and quarantine because they were going to lose their job. They were not able to, many folks were not able to quarantine because they had no access to funding, to housing. There were many folks who we heard from who were not able to quarantine for 2 weeks because they could not afford to shop once for 2 weeks and have enough their food in the house. So just really trying to think about what were some of those underlying causes, and we even getting into vaccination, right? We've seen a lot of mistrust in institutions that is very much based on historical experiences. We saw folks not being able to get to vaccination sites because they had no access to transportation. There were many, many underlying reasons why we saw the outcomes and inequities we saw during the COVID-19 pandemic. So we tried to bring all of that learning into our work alongside some of our SHA takeaways. And finally, I'm sorry, I just really wanted to spend some time elaborating on this particular issue because it feels very key to why we shifted our approach going forward. And then the final key takeaway there being that communities and individuals are experts on their own health and needs and their own barriers to health. So they should be part of all decision making that impacts their health. And the next slide is the last one that I will engage with you. If we could move to that. Very quickly sharing with you what are the implications for public health practice and how we're shifting our own work based on the learning from the past 3 years. The priority areas that you see at the bottom are the original ones that we had very much focused on health behaviors. So alcohol, nutrition and physical activity, opioids, suicide, and tobacco. During our SHA engagement in the COVID-19 pandemic, it became very obvious that if we don't address some of the key community conditions and some of the upstream work that needs to happen, our systems downstream, our treatment and care systems will become overwhelmed very, very quickly. So we need to address some of the community conditions in order to alleviate pressure and ensure equitable outcomes downstream too. So our team introduced the key conditions, recognizing that the work that's happening in the yellow spaces is still incredibly critical. It needs to continue to happen. It needs to happen in a more equitable way to see positive and equitable outcomes. But we need to address the community conditions to ensure that system and community resilience. So we introduced the and started focusing some of our work on improved social and community conditions, healthy environments and supportive systems, supportive and inclusive systems, and the transformative change to power structures that needs to happen, ensuring that that voices are represented at our decision-making tables. So I'll stop here, pause for a second. A lot of information presented to you in a short period of time. So just wondering if there's any questions, any clarifying questions, or any burning questions on what was presented before we proceed. Hearing none. We were hoping to be able to pause a little bit for some reflection. This is how our team learned from what we heard from our communities and from the processes, and these are the implications for public health practice. If we can move to the next slide. Really hoping to be able to reflect with all of you in smaller groups in a breakout sessions in terms of what are the implications of these findings to potentially your practice and clinical practice in general. How is this resonating with you? And then what is the clinical provider's role potentially in public health prevention?
And Maggie, I just wanted to
go ahead.
Interrupt here. I want to take a moment here to introduce Dr. Zapata, who's the Chief Medical Officer for Community Health at DHS. Dr. Zapata has joined us today, and she straddles this clinical space and the public health space really excellently. And I wanted to make sure we gave her the space to introduce herself now and also motivate some of these discussion questions since she helped us develop them. So Dr. Zapata, the floor is yours.
All right. Thank you so much. A wonderful job. I just am so thankful to your team for doing this amazing work. And when you told me that you all were talking to this group, I'm like, yes, the family medicine team is just so absolutely amazing at UW. And it's so important for us to ask ourselves these questions. And I know that these were some of the questions that I asked myself and was exploring as I navigated the traditional route through medical school, seeing patients, but then really feeling that tension, knowing that, wow, only 20% of these health outcomes are based on what I'm doing here. There's so much more that plays a role. But then the big question becomes, well, is it even my responsibility when I hear that there are housing crisis issues, there are inequities in the wealth accumulation? Like, I just went to medical school. I know how to prescribe medications, talk with patients, do my SOAP note, and that's my job. That's what doctors are supposed to do. The social worker can worry about all of that other stuff. But the question really is, and this is hopefully what we can delve into in the breakout sessions, what is the clinical provider's role in public health prevention? Is it for us to just do referrals to the social worker, or is there more that we could be doing? Is it even our role? How can we get more involved, and what implications does these state health assessment findings, what are the implications and takeaway for our own clinical practice? We do not want to just look at data and let it sit there and say, huh, that's too bad, or that's such a big problem. What are tangible things that we can do as a result of hearing all of this amazing information today? What can we do the next time we walk into a patient into a patient encounter or moving forward? There is already amazing work going on in this area, especially within the UW family medicine. There's already amazing work, and I want to acknowledge that, but how can we take it to even the next level? So I'll stop there, and I'm excited. Whatever breakout group you put me in, I'm really excited to chat, and thank you for allowing me to join you all.
Thank you so much for popping in, Dr. Zapata, and framing up the conversation. Incredibly helpful, and we know you're super busy, so really grateful for your presence in the space today. Would we be able to move into breakout sessions?
All right, here we go.
Just wondering, very briefly in a minute, either drop it in the chat, or if anyone wants to share a bit, fastest 10 minutes ever. Agreed, Dr. Zapata. If anyone would like to share any of the conversations that were had in the room, or any big conclusions or revelations with the rest of us, feel free to either drop it in the chat or unmute and share. There you go. We solved all the problems almost in 10 minutes.
I can get us started just real quick while we're waiting for people to unmute and tell us more. One of the comments that came up about clinical providers' role, a common theme that came up is that a lot of providers are just very busy seeing patients. And so then we took a step back to say, why is that the case? What would it look like if every new faculty member had 30% or 40% protected time to do admin and community outreach or public health work? What would that look like? That's changing whole systems, but we were just imagining and thinking about why is it the culture in healthcare that doctors work, 60+ hours and don't have time to do some of these things. And that could be a systems change that is very interesting to explore.
Yeah. Getting to the root cause there.
Yeah, and I think to build on that, thanks, Jasmine. I think that we talked about, or I'm going to do a lecture on value-based healthcare, and I think we just need to really change the pyramid of care and have a foundation where the foundation is public health and primary care, and the foundation is not hospital care and subspecialty care in the U.S. But that also then means payment reforms. And yeah, looking at how we can be advocates to have true payment reforms where more money is invested in public health initiatives.
Yeah, I love your framing, and it's always fun to build off Melissa. I love your framing, Jasmine, because I think there's a lot of opportunity, you know, at UW Health, and we've started in that work around trying to share more care with the team and having, you know, for example, behavioral health clinicians in our clinic to provide better access to behavioral health care. And likewise, we're starting to venture into social determinant screening and community health worker referrals for our patients at risk of poor prenatal outcomes. So that's exciting work that I think can be built going out. And we do actually have, through, you know, our alignment with courts and our ACO, the opportunity to shift more resources into this sort of work and this approach.
I love that. And one of the things that we were going along with that, talking about in our breakout, was just the importance of knowing that voice, clinical providers that are like boots on the ground, seeing patients, even just those stories are so important. They're even just sharing like, hey, I'm seeing that most of my patients can't afford this medication, or here's some issues that we're seeing. And then when you share that with people who are in that actually are in control of some of the systems and structures in the community, that can be huge as well. It can be large or small. So just sharing stories, our voices carry a lot of weight and can be very helpful for decision makers.
Very much hearing the themes that our team had in our last couple of slides too, and in some ideas that we generated. So really excited to hear the alignment there. Julia, would you like to share with the group kind of the things that we came up with as we were reflecting on those questions?
Sure. Whoever is controlling the slides, you can go ahead and move forward. You know, we know that you guys have taken on so much, that your time is so strapped already, and we're still going to ask you for the moon, because as much as it feels like our current systems and social climate, the doctors are like, you know, having just so much put upon them, and in many places being, you know, as people and as professionals being disrespected, and it's hard. Absolutely, we know that. And still, relative to your patients and relative to the systems within which we live and share, doctors are people who are, you know, who hold significant power. And so, you know, that has impact in those one-on-one relationships between you and your patients. You're a trusted voice, and it means you can be an important advocate for social, economic, and community needs that affect your patients. And so, you know, you can, with your relationships with your patients, you know, do consider those social determinants of health. I'm glad to hear that it sounds like that kind of screening is coming into better use. It's hard because you don't want to screen for something you can't treat. And so that's a place where you can use your voice to continue to build up those systems within UW, that those clinical community linkages are strengthened and are more easily available for you as a practitioner and for your patients to access. Leaning on that population health data that we showed earlier, and being aware of those health disparities and addressing the risk factors upstream that then can come into those individual patient patient interactions. And I do want to call out that it's a really delicate balance between relying on population level data and stereotyping. So just be mindful and be careful when you do that, and be aware of the biases that we all carry from living in the world that we do. And consider how your practices that you do have influence over in your practice can be adapted to systemically support those who have been marginalized and do, systemically have access to fewer resources. You can also, within your wider systems with your coworkers, with UW, thinking about everyone from your receptionists to your nurses, everyone else who has interaction with those patients, they may have a unique perspective on that patient experience and on the patient needs. So lean on all of those different folks. Considering whole person care, beyond, health, including well-being. You talked about partnering more with your social workers. Absolutely. Don't, again, we're asking the moon. Don't just pass it off to your social worker. Work closely with your social worker and your community health workers and your behavioral health therapists. Those are such important partnerships to build and develop and grow. And then get involved in efforts to address structural racism and institutional bias across the systems of care. This can be done both within UW, and if you've got the time and the energy, we really would love to see you taking roles for wider advocacy at the political level. Next slide. I think I'm allowed to say that. I don't know if I'm allowed to say that as a government employee, but I did it. I'm sorry, Maggie. So yeah, use your voice. You really do, relatively speaking, have the power. And so we, encourage you to be aware of the resources you do have, and take advantage of them. And just always be advocating for those population health level things, either as an individual or by serving on a committee or by serving in an advocacy organization or being a board member somewhere. Be that health equity and population health advocate that we know we need. And also, shameless plug here at the end, we are beginning this process of identifying our priorities for the next state health improvement plan, and we will be engaging with all sorts of partners, including healthcare organizational partners. So keep your eyes open for some invitations that could be coming your way later this year. And we would love to hear from folks like you who do care about those patients. And that is what I will say. Anything to wrap us up? I know we have like 2 minutes.
I just wanted to share with the group, be really grateful. We're really grateful for your very own Shelley Shaw for her contribution to the state health plan, and she was representing your department in terms of anchor institutions when we were going through all of the learning from the state health assessment and discussing how we pivot our work based on the learning from the state health assessment and the pandemic. So kudos to Shelley, and looking forward to engaging with all of you.
Thanks so much, Maggie, and thank you all so much for coming today and sharing with us all of the amazing work you're all doing, and also providing us some opportunity to talk with one another and consider the ways we can step into this work. We probably have a little time for a few questions. Are there any questions from the group? And maybe Vanessa, we could probably take down the slides.
Shelley, this is Patricia. Thank you for the presentation. It was wonderful. A couple of things. One, following up with why is that some of us don't do it or do it. I think in my case, for example, when I started as faculty and then when I needed to go up for promotion, I learned that even though this is so important as we are talking about it today, the requirements for promotion do not include a lot of these. So if you can do something and try about it, then maybe. But if you do a lot because your community needs a lot, but you don't have the time to write about it, it doesn't count, basically, for promotion. So I have been at the department now for 22 years as faculty. That has not changed. So where do we start that process of actually putting importance into public health and community work? I mean, we even changed our name at the department, we changed the name at the School of Medicine, but yet for promotion, this is not really counted, right? So I just got an email, very nice, inviting me to maybe apply for full professor. And the issue is if I do that, then my community will suffer because I will not be able to continue providing for my community. So where do I find the time to do that and my clinical work and my mentoring and et cetera, right? So something to consider as a system, really changing what the requirements are for promotion so that people will be more likely to want to be out there in the community and doing things. The second thing that I was commenting is that I really like that you say in there that communities really know what they need and they have resources and they are resilient. However, that is not enough when we don't have resources. And unfortunately for the Latinx community, we are invisible. And we're invisible because, oh, you are undocumented, you don't pay taxes, why do we give you resources? Which is not true at all. The majority of the Latinx in the United States actually are citizens and pay taxes, and the majority of the undocumented pay taxes too. But for some reason, the system always has priorities over other communities, other issues, and we're always left last. So I think I'm glad to see that you talk about some of these things in the plan, because it is time to put every community, I'm not just advocating for the Latinx, but every community at the same level. Because when you put us on different levels, you also cause internal problems among us. Why is that the money is going to this community, but not to this community? And then we have trouble even relating to each other. So we need to label, the ground for every community so we all thrive together. And COVID definitely showed that, right? What communities were the most affected and why, and what resources we were able to get. So thank you for the presentation.
Can I say a quick comment? I know we're close on time, but about the comment about promotion, I love that. I heard that recently the promotion packets and descriptions about what you can go up to promotion were updated to include more public health and community practice. So when you look up like the appointment packets, it tells all of the things if you're assistant professor, associate professor, or going to full professor. So it used to be you could go up on like, it was clinical, education, research, but now it's clinical/public health. That's huge. And one of them is education. So as you are mentoring young faculty or even people who are interested in public health, this is just an example, but my promotions team, they knew that I love doing a lot in the community. So listen to just some of the examples of education. When you go up on education, you can have one of them is establishment of a community program or partnership to further medical or public health education. Frequent invitations to present and teach at conferences, workshops, or things like that in the community. You can have establishment or implementation of novel clinical approaches for improving patient care. So some of these things, there's a way that if you frame a lot of the amazing work you're doing in the community, that's education. Even if you talk to policymakers and say, here is what we're seeing, that's education in a way. So anyway, I'll stop there, but there's ways we can get it in. And I know that they recently revised that over the last few years to try to incorporate some of that important work that you mentioned into it, because it's not right that you can't get credit for those amazing things in promotion.
And thanks all. Jennifer, did you want to say something?
Yeah, I mean, I just put something in the chat, and Patricia and Jasmine, it's such an important point about the promotion. And so there is actually a group who are continuing to challenge SMPH to update guidelines around promotion. And I hope you don't mind, Patricia, I was actually thinking of you as an example case of why you are not a full professor right now, given the kind of work you do for really representing the School of Medicine and Public Health. And that really struck home to a lot of people on that subcommittee. So I just want you to know the Dean's office is actually looking at this very thing in terms of revising promotion guidelines. But yeah, holding you close when I go to those meetings.
Thank you. Happy to support this in any way I can.
All right. Well, thank you all so much. And thank you again to our OPA colleagues for joining us today and taking all the time. Really appreciated the conversation.
Thank you so much for having us. It was wonderful to meet you.
Thank you all. Really amazing conversation. You really seem to get the systems level stuff we're talking about. So love to hear it.